Hello, everyone, and welcome to the latest edition of ALNAP's Urban Webinar Series. My name is Leah Campbell. I'm a Senior Research Officer at ALNAP, and I lead our urban work that this webinar falls within. This is our 21st urban webinar. We do a few of these a year and try to bring together practitioners who are working on really interesting humanitarian response in urban areas around the world to share the experiences they're having on different topics. And this webinar, we're focusing on how to find and respond to the needs of hidden or marginalized people in urban areas. I'll mention just to get started that the idea for this webinar, the theme of this webinar was really informed by ALNAP's annual meeting, which we had last October. We just actually published the meeting paper relating to that meeting, so you can find that on the ALNAP website in case you're interested in this theme more broadly, and in particular thinking about the relevance of aid that gets provided and questions around who decides about relevance. So today's webinar, we have two speakers who I'm going to introduce to you in a moment. And while I tell you a little bit about them, we'd also be really interested to find out a bit more about all of you. So we're going to put up a quick poll just for you to tell us a bit more about who's listening to the webinar today. There's only a couple of responses, so just pick the one that fits you best. While you do that, I'll tell you a bit more about our two speakers for today. So our first speaker is going to be Valerie Rolls. Valerie became Relief International's country director in Lebanon in 2015, having previously served as the regional program development manager in the Middle East for 4 years, also at Relief International. She was also country director for Jordan in 2018, and then moved back to Lebanon in December 2019. So very experienced in that region. Valerie also played a lead role in setting up Relief International's response at the onset of the Syria crises across the region, and has subsequently provided leadership in carrying forward both the Lebanon and Jordan country programs. Previously, Valerie worked for Internews in senior roles, including business manager for the Middle East and North Africa. She holds a master's degree in Arab and Middle Eastern Studies from the American University of Beirut. And Valerie is going to be our first speaker today, talking about support for those with mental health needs in Lebanon. Then we're going to have our other speaker, Katie Sussman. Katie is the technical lead for IRC's Northern Central America protection programming. Katie has over 10 years of experience working in Latin America in international development, education, and humanitarian response, particularly focusing on violence prevention and response, child protection, and gender equity programming from a feminist perspective. She has experience in Brazil, Honduras, Guatemala, Bolivia, Ecuador, Colombia, Venezuela, Mexico, US border response, and is now working in El Salvador. She has a double master's degree in social work and international development from the University of Denver, and specialized in gender-based violence and human trafficking at the Institute of Judicial Studies from the Judicial Power of Nicaragua. She has particular experience working with vulnerable populations affected by violence, forced displacement, trafficking, gender-based violence survivors, and rights-based programming in Central America, and is particularly interested in how technology and non-traditional approaches can be used to reach hidden populations, as well as how trauma-informed care in secondary and tertiary violence response and prevention can be effective. So those are our excellent speakers who are going to be telling you more about their work with marginalized populations in just a minute. So to get back to who you are, we always have quite a variety, although far and away, most of you listening on the webinar today have had some experience with marginalized populations, perhaps in urban, perhaps not, though not very much. Only a few of you think that you should have been asked to be presenters on this webinar, and a couple of you have never responded with urban marginalized groups. So the good news is if you've got some experience, you'll be able to follow along with the presentations we have for you today, and also hopefully it'll be interesting for you to learn a bit about these particular projects. So I'm going to hand over to our first speaker, who will be Valerie, to tell us more about Relief International's work in Lebanon. Over to you, Valerie.
So thank you all for the introduction, and thank you for your participation and your interest on this topic. So I will just go ahead and jump right in, and I want to kick this off with a poll. So the poll is, in Lebanon, approximately what percentage of Syrian refugees live in formal refugee camps? And while you're answering that, I'll just go into a little bit of background about Lebanon. So as many of you are probably aware, Lebanon has been consumed by the Syrian refugee crisis since 2005, and currently there are an estimated 1.5 million Syrian refugees in Lebanon, in addition to other refugee populations, most notably the Palestinians, who are an estimated 300,000 people in the country. And this is in a country that had an estimated population of only 4.5 million Lebanese before the influx. So this makes Lebanon the country with the highest number of refugees compared to the host population in the world. So it seems that many of you will then be surprised to know that in Lebanon there are actually no formally established refugee camps for Syrians, which means that 100% actually live in urban settings. So I see that not everyone was aware of that. And it really means that the context for Syrian refugees in Lebanon is a bit challenging. Approximately 70% of Syrian refugees live in buildings, which can include apartments, but also collective shelters, substandard buildings, and other arrangements, such as within garages, construction sites, shops, you name it. And then there's the other 30% who reside in what we call informal settlements, which are groupings of tents. Some are large groupings with hundreds of tents, and some are much smaller with just a few, but they're on private lands, which are dotted across the country, and they have absolutely no formal status. So regardless of the structures in which they reside, Syrian refugees are part of the urban fabric of the country. They live in both large cities and in villages, and they live side by side with Lebanese, and mostly in areas of the country where Lebanese suffer from higher levels of poverty than in others. So in the map here on the slide, you can see that the larger circles actually indicate the higher concentrations of Syrian refugees, and in these areas, these are also the more highly impoverished ones within Lebanon. As such, as humanitarian actors, we consistently strive to ensure services are provided to both vulnerable Syrian refugees and vulnerable Lebanese communities to the extent possible. And so this also applies to our programming, our mental health programming. Relief International has been active in Lebanon since 2006, and we've evolved our programming over time to meet the changing needs of the most vulnerable communities. Currently, we work in 4 sectors: health, education, cash, and livelihoods. And similar to our global portfolio, it's our health program that makes up approximately half of our country program. And we are seen as significant actors in the health sector here. Our approach to mental health is ensuring that it's integrated with healthcare, and we have been doing this since 2017 when we began to build our mental health programming unit. In addition, we do link our mental health services to the programming we implement across all the sectors, and we ensure that we are working in full coordination with the Ministry of Public Health. So I think we all understand that mental health is important for all of us, but why is it especially important for vulnerable populations? So not surprising, vulnerable populations, they face challenges that increase their risk of suffering from mental health issues, and they're generally factors that that most of us take for granted in our daily lives. They suffer from poor health, hygiene, and living conditions, which are interlinked and raise anxiety and stress. They often have a deficiency in meeting their basic needs, which includes challenges with paying rent, affording food, lacking access to education, to livelihoods and income generating opportunities, which also exacerbates anxiety and leads to depression. And then many of the populations we serve face insecurity, both external, linked to authorities or crime, and internal, for example, with higher levels of domestic abuse. And then for refugees specifically, they do face challenges with lack of rights, and there's issues of social cohesion within the host community that can also present stresses. And I think it goes without saying that many Syrian refugees have also survived truly traumatic experiences during the war in Syria, and then not to mention being displaced in itself is quite traumatic. And then finally, which is something we'll touch on a bit more as well, there is a lack of awareness among vulnerable communities about the importance of protecting mental health and the services that are available to support them. At the time we started our mental health programming in 2017, the landscape for mental health services was quite bleak. In Lebanon, private psychotherapists and psychiatrists charge high fees, and they're mostly reserved for the well-off who can afford the services. And in addition, most are not trained to deal with extremely vulnerable groups such as refugees. Given this context, while there was a very high number of agencies providing psychosocial support through various types of programming, the specialized one-to-one services were extremely limited. And it wasn't until 2016 when the Ministry of Public Health began to focus on mental health for more vulnerable populations in the country by introducing MHGAP to the ministry's network of primary healthcare centers. And RI was one of those agencies that were at the forefront, and we were playing a significant role in supporting the ministry to ensure primary healthcare centers were adopting this new approach. At the same time, there was a general lack of awareness about the importance of mental health and a severe stigma attached to those who sought such services. So in this slide, you can see Relief International's approach to mental health in Lebanon. So first, we identify the need. And how are we doing this? So because we are working in an urban setting and not, for example, in a formal refugee camp setting, identification of those in need of mental health is actually a distinct challenge. We address it through door-to-door visits by trained community health workers within the neighborhoods and informal settlements where we implement. And as you can imagine, this requires manpower and time. Through these visits, our community health workers provide awareness and identify individuals to refer to our social workers for follow-up. In parallel, they are also taught about the pathways to access our mental health services, but also going directly to the primary healthcare centers. Once an individual is identified as in need of services, our social worker will assess each case and determine the level of mental health care required. This could be provision of one-to-one psychosocial support sessions through social workers at home, could be specialized one-to-one psychotherapy with our psychologist, or it could be psychiatric care to be provided by our psychiatrist. And then the patient is subsequently enrolled in our mental health program, which is our step 3. And of course, during step 3, we're also setting the schedule for the service provision with each patient. And then this leads us to step 4, which is the provision and continuity of the service until we can consider the case to be closed. There's actually no formula for how many sessions will be provided to each patient. It's very much dependent on the needs of each individual and on a case-by-case basis. But we can say it usually ranges from between 5 to 10 sessions. The service provision by the psychologist and the psychiatrist is done at the primary health care in a safe and private environment, and we are also therefore working with the government public health system in coordination with the Ministry of Public Health. And I just want to highlight here that through this approach, we really are not only coordinating with the ministry, but we're also ultimately helping to strengthen the ministry's approach. In exceptional cases, we do provide sessions at home in the case where a patient's mobility is limited. So here you can see the most common mental health issues that we're seeing for our patients, which I'm sure have a lot of similarities with other humanitarian contexts. It's post-traumatic stress disorder, depression, anxiety, sexual abuse, threats of suicide. And of our caseload in particular, we're seeing about 48% experiencing anxiety, about 37% experiencing depression. And just so that's the majority of the symptoms that we're seeing. But just to highlight here that most of what we're finding with our patients, the conditions do not come alone. So there's often compounded issues. And of course, again, each case is quite unique. So through our several years working directly with patients, we've just come up with some lessons learned specifically when we're dealing with patients. And just mentioning 3 here. So first, the brief psychotherapy. We learned that it's important to keep the sessions as focused as possible and minimize the number of sessions so that the problem can be addressed quickly and to mitigate the risk of the patient's discontinuation from the program. Secondly, which is, I know, quite obvious, but it's building a good rapport with the patient. And it's just important to highlight because if the patient really needs to feel comfortable with the mental health worker so that there can be an honest communication channel in order to have the best results. And then finally, we learned that sessions should include a focus on tailored plans to enhance the patient's ability to stay as resilient as possible and to build their coping strategies for the future with concepts and tools available to them without the support of a psychologist. So this will help them better cope in the future challenges they face, and it also will help because they can contribute what the knowledge and tools that they've learned to cope and impart that to their family and their neighbors. So I'm just highlighting here some of the key challenges that we face in implementing our programming in an urban context, which I think has its own set of unique challenges. So firstly, there's the stigma, which we have mentioned before, and we believe that actually operating in an urban context will exacerbate this issue of stigma because going to the center to seek services cannot easily be hidden. Through the awareness sessions that by RI and efforts of other actors, we have seen some of the stigma improve, especially for refugees, but we're having a more challenging time with Lebanese. Secondly, because one-to-one specialized support from psychologists and psychiatrists is offered at primary health care centers in communities, many of this can pose challenges that would not be faced in a formal refugee camp setting, where the path from the home to the health facility within the refugee camp is clear. So in the urban setting, individuals must pay for transportation to reach the center, and in many cases, this is really an additional burden for the extremely poor households that we're working with. Also, patients may have difficulty getting to the center when there are extreme weather conditions or there's protests that block the road. And in Lebanon, this actually happens more frequently than you might expect. So we do mitigate these access challenges by ensuring that the primary health care centers where our psychologists and psychiatrists work are in relative proximity to areas where we're providing awareness, and the link between the community health workers and the centers is clear. However, there are some cases in some areas of the country where this is more challenging, and in those cases, we will do our best to refer to other providers if available. A third challenge is the lack of high availability for clinical psychologists and psychiatrists, especially living outside of the capital Beirut, especially as most vulnerable populations are living in other parts of the country. So for RI, with our mental health programming, it's currently focused mostly in Bekaa in the north, and this is a minimum of a 2-hour drive from the capital. Often it's actually longer depending on the location. And to manage this challenge, we actually don't have a one-size-fits-all approach, and we try to be flexible. And it depends very much on the individual that we're trying to hire. So in some cases, it could be that we're supporting their relocation to be based in other areas of the country. And in other cases, it could be that we're just providing daily transportation from Beirut to the field locations. But in both cases, it does require additional financial resources. A fourth challenge, which I think is felt by all, is really just the sheer volume of need compared to the capacities available. So it's really a nationwide issue experienced by all mental health providers. And a good example is with RI's program. Currently, we have over 200 patients on our waiting list, and we know that this number could actually go higher relatively quickly. So a final challenge that I just want to highlight within this presentation is the difficulty for NGOs to secure reliable funding and support of mental health. I think in some cases, donors still see this intervention as an add-on or something that we can integrate within other programming. And of course, we agree that mental health should be included to the extent feasible within any humanitarian intervention. We do also want to advocate for really a well thought out approach to ensure that the provision of the specialized care that is needed is actually available. And this, of course, requires resources. So there's the cost of a highly specialized staff, the cost for their transportation, the cost of supplies to work with their patients. And in addition, we find that donor support for mental health so far is mostly linked to humanitarian donors, which rarely provide more than 1 year of support at a time, and often it's less. And the short nature of the programming does pose challenges for the timelines of our caseloads, and it can also complicate our relationship with communities because we don't have assurance of a more long-term presence. So just to wrap up, I just wanted to leave with a few key takeaways. The first is really just highlighting and underscoring the importance of mental health and humanitarian response. Having a foundation of mental health really does underpin the success of all other aspects of an individual's life, including physical health, relationships with family and community, success in the classroom, ability to earn income, and other needs, of course. And as such, mental health is really truly a component of primary health, and it should be prioritized as a key humanitarian intervention provided to vulnerable populations, which will also support the success of other programmatic interventions across other sectors. So it's not only good for individuals, it's also important for building healthy societies with performing economies and communal security, because if a significant proportion of the population is suffering from mental health issues, it will have a negative ripple effect on the society at large. The second point I'd like to highlight is that mental health should support existing systems and structures for sustainability. Especially in urban contexts, mental health programming should not be implemented in a vacuum, and it should be linked to and in support of the existing health structures within the country. So in the example of Lebanon, the Ministry of Public Health opened a mental health department in 2015, and our programming is designed to fit in and also support the strategies and policies being put in place by this new department and ensuring the needs of vulnerable communities are being addressed. We believe that it is the responsibility of international NGOs operating in urban contexts to contribute to strengthening national systems in order to support the overall sustainability of mental health service provision within the areas where we're working. And finally, I just want to, I guess, reiterate about the resources required to implement mental health. Of course, it can be implemented in any context, including urban settings, but to do it, we really need the resources to support it. And because the outcome of mental health programming is not as visible, for lack of a better word, as some of the other interventions in the humanitarian space, we can often be overlooked for donor support. I will say there have definitely been huge strides in the right direction within the humanitarian community within this regard, but I do think we have a way to go. Thank you all.
Great, thanks so much, Valerie. That was really interesting, and we already have a bunch of questions coming in. So I wanted to ask you one specific one about your presentation before we go to something more general. We had a couple of questions about the relationship you just mentioned in your takeaways again there with the public health ministry or department in Lebanon. So the question in particular, if you could elaborate maybe a bit more on two parts. What sort of capacity building support do public health authorities in Lebanon need? Basically, what are the gaps that you've identified in terms of capacity building support required by those authorities? And how did you go about building the relationship with public health? And did you have any challenges in doing that? And how did you address those?
Okay, thank you. That's a very good question. If I may, just a little bit of additional context for the Lebanon specific. In Lebanon, the public health system, when it comes to primary health care, it's actually the primary healthcare centers are actually, for the most part, there are a few exceptions, but for the most part, they're actually privately owned. And they are enrolled in what's called the primary healthcare network. The primary healthcare network is for those centers that meet the criteria to be enrolled, and from that, then they benefit from the services and the support of the national ministry. So of those that are enrolled, there has been a movement for from the Ministry of Public Health with the creation of this new department for mental health support to integrate mental health within those centers that are enrolled within the network. I mentioned that they're rolling out they have already rolled out the MHGAP. And by doing that, they're actually training the medical care workers within the centers on safe identification and referral for those who might need additional mental health services. Ideally, each primary healthcare center actually would have their own psychologist on staff. And what we find as a major challenge is that many centers cannot afford this. And so, for example, the psychologists and the psychiatrists that we have on staff as RI, we've vetted them in the centers, but they are actually RI staff. So I think that one of the main challenges is honestly just the lack of resources to staff appropriately those primary healthcare centers that are within the network. In terms of relationship building, to be honest, the Ministry of Public Health within Lebanon has actually, they've been quite welcome to working with NGOs where it can support and fill gaps. So it's really just been a matter of direct coordination, specifically with, in the case of mental health, with the National Mental Health Department. And we've actually had some just really good open dialogue and understanding about the direction that they want to go and how we can support that.
Great, thanks. And I wanted to ask you one of the other questions that's come in that's a bit more broad in terms of relating to all different sorts of marginalized groups. One of the questions that's come in is is there a difference between hidden groups in an urban context or any humanitarian context even, hidden groups who maybe don't want to be seen, and invisible groups or individuals, people who are unseen by external actors, but perhaps very much hoping that their needs might be seen and met? And is there a difference between them and how you can support each of them? Do you have any thoughts on that one?
Yeah, sure. So I will say that there 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 can be a difference, but not always. So it depends on the case. So we do have people in need that are invisible within the urban context and not always easy to locate. In the refugee context, they may or may that these would probably be the Syrian refugees that are not registered with UNHCR, so they're less easy to locate. But that doesn't mean that they don't necessarily want services. There are some, however, that do not want services and they choose to remain hidden. I think that as humanitarian community, for those who choose to be hidden and they do not want to benefit from services, that's their right. But I think we need to make sure that they are aware of what is available so that they do have access to them in case they would like to. So I would say that the approach for both within the context of our mental health programming is actually similar, because what we do in terms of outreach is on a door-to-door basis. So we are talking with communities at large, those who want assistance and those who don't. In addition, because we are ensuring that the populations that we work with are aware of access to the primary healthcare centers as one of the key avenues for just directly accessing mental health services. Those who choose to be hidden, if they decide otherwise, they can always approach the centers as well directly.
Great, thanks for that. So we're going to turn now to our second speaker, Katie, who's going to tell us a bit more about IRC's work supporting LGBTQ individuals in El Salvador. Over to you, Katie.
Great, thank you so much. Thank you, Valerie, for that very interesting presentation, and thank you all for being here. So today I'm going to tell you guys a little bit about how we reach marginalized populations, specifically in El Salvador, and how we can start where they are. I want to set the scene a little bit. In El Salvador, we have around 8 million people. El Salvador is about the size of Connecticut, and it's a very small country. It borders Honduras and Guatemala, and has a long coast with the Pacific Ocean. And it really has a very interesting history. In El Salvador, it's gone through a civil war that lasted for 12 years. And really the population, especially the older generations, are very traumatized. And there's a lot of intergenerational trauma that sort of is pervasive throughout. They've had quite an interesting turn in this past year with a new president who is named Nayib Bukele, and he has brought sort of a very progressive young voice. He's a young president, and has kind of shattered the typical bipartisan politics that were within the country for so many years. Unfortunately, there still is prolonged violence and internal displacement, and it's not really seen as your typical humanitarian crisis. And this really goes for all of Latin America, but specifically in the Northern Triangle, or Northern Central America, as we're now calling it, and in El Salvador, you see this violence has been occurring for years, and that has gone from a civil war to armed groups, gang control, and effects of long-term narco trafficking on the population. And unfortunately, up until just about 2 years ago, did even donors or academics start seeing this as a humanitarian crisis. So what do we do in El Salvador as IRC? The International Rescue Committee in El Salvador sort of is an anomaly in the sense that we are pure protection programming. So we came into El Salvador, and we really saw that there was a need for access to information and services. We run an information and access to information platform, which is called QUICKPOLL, and it's an area where we have geo-referenced services, and then have a space where we provide information 3 to 4 times a week and are constantly updating that. And then we also have a two-way messaging service in which people can talk in real time via WhatsApp with a live moderator regarding their needs, and that either then turns into some crisis referrals or into giving them the information about services that they need. We do capacity building with local government, specifically in sort of applying those protection principles. There's a very rich history in Latin America, and specifically in Central America, about the local civil society. Lots of local organizations doing amazing things, and really a lot of them have come out of responding to natural disasters or responding to more of a development context. And so trying to sort of put a spin on what they're doing and apply some of the humanitarian principles and protection principles specifically, and having them look beyond and sort of the surface and see that the violence is also a humanitarian need and crisis. We do safe spaces specifically for the LGBTQI population and for women and girls. And we also provide rapid support through humanitarian cash assistance in sort of an innovative way. And our focus here in El Salvador, specifically in the urban area, San Salvador and some other cities, is on returnees and particularly vulnerable populations. And for us, that means women and girls in the LGBTQI population. And when we say returnees, these are typically from the United States or from Mexico, and they've been deported. So I'm going to tell you a little bit about CUENTANOS. This is the homepage, just so you get an idea of what it looks like, and what it has to do with the current situation, and why we chose to come in and not provide direct services, but rather fill a gap that we saw within the space in El Salvador. The current situation, specifically in Northern Central America, in this past year, there's been more than 712,000 internally displaced people in a very small geographical area. And when we say more than, it's because we know that the statistics and data that we have is very little. Unfortunately, because it hasn't been considered a humanitarian crisis, we have very little data to work with. And just now are we, getting sort of more involvement from the United Nations and UNHCR and trying to count that number. We are also just now in El Salvador getting support from the government and even recognizing that there is an internally displaced population. In December, the President Bukele finally passed the internally displaced population protection law. Before, the government would not recognize that there was this population. They just called them internally moving population, rather than recognizing that they had this population within. And then we see more than 500,000 people fleeing north a year. So if you think about a population of 8 million, which albeit hasn't been updated in several years because they go by census numbers, but that's quite a large number going north a year. So this sort of complex needs and sort of mandate a transformation and creative rethinking in what a humanitarian response looks like. And we couldn't do the typical humanitarian response that we may do in other crises. And that's what brought us to set up this interactive user inputted platform, information platform, because we found that in times of crisis, people are desperately in need of information about where to go and how to access those vital services. Up until now, we've had over 208,000 page views, 7,017 users, and 17,092 sessions. So when we talk about the vulnerable population in El Salvador, we are particularly focused on the LGBTQI population, especially trans women. And we get this question a lot as to why do we focus on trans women? Trans women have an average lifespan of age of 33 in El Salvador. So the amount of people that are killed or die violent deaths within that population, 68% of them are homicides of trans women. And so we really know that they're the most vulnerable because they're the most obvious, and they can't hide as well as other populations within the LGBTQI population, and that really makes them a target in a very machista society. People living in gang-controlled areas. Now, all of El Salvador is affected by gangs, and I'm going to talk a little bit further on about what that means, gang-controlled versus gang-affected. Women and girls, it's not a coincidence that trans women are the ones that are most vulnerable within the LGBTQI population. Women and girls are especially vulnerable within El Salvador as well. And unfortunately, the rights of women and girls are also very, still very remedial in terms of being able to access sexual reproductive health care, really being able to have a full place in society. But if you would look at it from a superficial level, it wouldn't look like that. And so it's something that's very normalized. And then we look at returnees and their families. Returnees and deportees and their families are at a special risk. These people are usually coming back not at their own will from the United States or from Mexico, and they are specifically under threat because a lot of them left because of potential threat for their life. Many of them left because they were being forced out of their homes by gangs, or they were being extorted, and if they didn't pay up, they were going to get killed. And so it really puts them at higher risk. And then there's also some very cultural interpretations around returnees and deportees. Many people perceive them to be less than. They perceive them to have some sort of gang affiliation. And so then it's very hard for them to get reintegrated back into the urban society. Some of them come back after 5 years, some come back after 35 years, and with nothing but a backpack. And then we look at the internally displaced population. We know that once a person or a family is internally displaced within El Salvador, they are exponentially at risk to be displaced again and again. So I want to do a quick poll with you all, and I want to find out what you think about the access to internet and technology. And you're going to see why I'm asking this question later on. How many people do you think have consistent and reliable access to internet in El Salvador? And it should be interesting what you all come up with here. Okay, so the majority of you think 15%, and then 60%. Those 60%ers, you got it right. Yes, over 60% of people have consistent and reliable access to internet in El Salvador. This is quite a dichotomy because we do see that the average El Salvadoran only has 6.8 years of education. So we know that people are connected, and we know that people have the technology to be able to get connected. 95% of people that answered a recent needs assessment that we did have smartphones. 95%. And so that's very abundant in a population that has a relatively low education rate. And that just kind of shows us how much they rely on technology to create their community. And then we specifically found that discrimination, exclusion, and poor treatment really dissuades the population to seek services, especially the LGBTQI population. This community is very closed, and it's closed because they are protecting themselves. And so if they feel like there's any threat or any risk to their safety or well-being, they choose just not to seek those services. And then we also found that social media is actually the first place for hidden populations to turn to for information. So this is quite interesting because even in some of the more rural areas, we know that, you know, urban settings that make a little more sense, but this is in general in El Salvador. We found that Facebook is one of the biggest resources that people use to find their information. And then we also found that safety is absolutely key for people to seek information and services. And we're not just talking about physical safety. Yes, that's a very real need in El Salvador, but also emotional safety, feeling safe. So I want to talk a little bit about what are the barriers. So we know the needs, but what do we have to do to get across these obstacles that we have? And some of these barriers are just very rooted within a society that has normalized violence. Violence has existed since people were born, and maybe for the older generations it existed in the form of the Civil War, and now it's turned into gang-related violence, but it's a part of daily life. People have figured out how to manage within those restrictions of normalized violence. And if that means that they are restricted to invisible borders within their community, and they can only go within a few blocks radius because they know if they cross that invisible border, they could be potentially killed, that's what they do. If that means not going out after 7 p.m. or not taking transportation after a certain hour, or just knowing that whatever you're carrying at any time could get held up by gunpoint, that's just something you live with. That causes a lot of fear that builds up, that really builds up in the population, and a lot of mistrust. And so in El Salvador, you will find that people will be very hesitant to share information with you. And that's because they're protecting themselves and they're protecting their families, because that's one of the main ways that gang-affiliated groups get their targets in terms of extortion, particularly. There's a lot of stigma, and that stigma is strong. There doesn't need to be a physical barrier for returnees and deportees specifically. That stigma is strong enough for people to be confined to their house and not leave to seek services, to seek psychosocial support, to seek employment. There's a lack of resources, right? El Salvador still has very high levels of poverty. So that is a real issue that sort of comes to cross with the high levels of violence. And then the lack of knowledge of services. Finally, this population in particular is a moving target. We know that our population, our target population is always moving, and that means because they're consistently displaced, they're consistently having to move locations, and so it's a harder population to be able to reach for purely logistical reasons, beyond all of the more emotional security reasons and trust. So I wanted to just show you an example of what we're talking about when we say invisible barriers. Here you see a map just of San Salvador, and this is just showing the control that the armed groups or gangs have within the city. You can see that all of the colored in areas are gang controlled, and the areas that just have a colored border are gang presence. So when you have a gang controlled area, the people living in these areas have very tight norms and restrictions. They know who is the leader, and they're not your typical community leaders. Their leaders are the leaders of the gang within that area. And you have to work within the confines of whatever they set up as the norms within the community. And that becomes quite complex when you're talking about internally displaced people. If somebody is being threatened in a green area, they may not be able to go to an orange area. And if they're being threatened in a blue area, then they can't go to a green area, because then they could become a larger target for that other gang. And this is very representative of many municipalities within El Salvador. So what is our conclusion? Our conclusion is that we cannot fit a circle in a box. It's just not going to happen. So we need to really reimagine what our interventions as humanitarian responders are going to look like. So that brings us to the conclusion that we need to start where people are. We aren't going to have the luxury to be able to have the people there and have them trust you to provide them services de una, as we say in Spanish, right away. So what does this mean, to start where people are? Starting where people are means that we need to start where they are physically and also emotionally, and give them the space to be at the center of the intervention, to really lead it, and to give us the idea of what's the pace we should go at, and where do they want to receive services. And how do we do that? Is sort of what have been our lessons learned in doing that? How have we been able to achieve that, and how are we continuing to do so? For IRC El Salvador, we've utilized diverse entry points. So that means that we really have supported ourselves on trusted partnerships. And the first thing you have to do is listen. You listen to those partners, and they may not be your typical partners. You may need to talk with the women that work in the local pupuseria, or the people that are doing sort of work within that particular community, rather than just organizations, and know that particular marginalized groups have trust in others that may not be your go-to CBOs. And so really listen to who they are and what their experiences are, to learn what works for them in terms of providing services. And that brings us to mobile programming. So we know that static programming, specifically for this population, it has a lot of challenges. One is being able to really reach the amount of people that you would like to be able to reach, given all of the security challenges and free movement challenges that we experience in El Salvador. And so really looking at innovative ways of how can we bring the programming to them. And that is quite difficult at times, because you have to balance that with also taking into account safety and security for staff, for volunteers, and for your own personnel. And we do that through some unconventional programming, really focused on places where people already go. Where do people already go on a day-to-day basis? A lot of women in El Salvador may go to their beauty salon, and they may not go there because they're getting their hair done, but they go there because they want to share with other women. They may go to the local pupuseria or local eating joint, and many of them still go to remittance agencies to pick up remittances. So that's something that we used as a lesson learned for our cash programming specifically, in rather than providing cards or putting people at risk by providing cash, we used a mechanism that was already there, that people were already using, already knew, already felt comfortable with, and really just use that. And so we provide our cash support through remittance agencies, where they can go and just pick up the money. And then we also have to look at sort of really diving into strong, while safe, social media outreach. We know that this particular population, especially the LGBTQI population, they are very insular, and their way to reach them is through social media first. I recently was speaking with a trans woman, and she said, we find our friends online, we find our partners online. It's only natural when we are in crisis that we seek support online. And so that really resonated with me. And I think that's something that we are continuing to always do now. And then we have to provide communication mechanisms that are not sort of program driven, and in terms of our idea of who is it, we want to know about them, what's the demographic, but providing anonymous communication mechanisms that really puts the needs of that population first, rather than the needs of us wanting to collect information about that population first. So we do that via WhatsApp, a lot of other ways that can be done as well. That's just one of the platforms that Salvadorans tend to use. And then bringing information and services to their fingertips and taking out that middleman. So typically, Salvadorans, to be able to get information or services, they would have to go to an organization, ask, or go to a government entity and ask, and just to be able to go there and ask creates a lot of barriers for them. So really bringing that to their fingertips, online, they can go and look, and allowing it to be directed by current events, needs, and available services. So constantly changing, constantly updating, and validated. So not just a typical sort of service directory, but something that we have gone and visited over 120 service providers, 1,200 points of service, and really knowing that where you're looking is it's trustworthy services, and then allowing them to also participate in creating information. So we do 3 to 4 articles a week on the QUICKPOLL platform, specifically regarding current needs for the population, and that's absolutely dependent on what kind of questions we're getting via our two-way communication mechanism, as well as what we're seeing on our social media that are their needs at this moment. So that's what I wanted to share with you today, and I, really just want to emphasize the need to start where the population is within urban settings with particularly marginalized groups, and starting where they are is the way to be effective. Thank you so much.
Thanks so much, Katie. And I'll have a couple of questions to follow up you, and then we'll kind of evolve the rest of the session into a Q&A and bring back Valerie's thoughts as well. The first question that I have following your presentation that someone has submitted is, can you talk a little bit about any partnerships that IRC have built with the local authorities in El Salvador, and how helpful those may or may not have been for you?
Absolutely. Yeah, partnerships, particularly with the local authorities, have been key, and that's because we know outside of San Salvador, we know that the local authorities are the sort of those that have the power and have the word. So if we get them on our side, and when we're talking about local authorities, we're talking about municipal level. We have worked at the country level in each department, and with municipal actors hand in hand. And so everything that we do, particularly with QUICKPOLL, and with our some of the campaigns, communication campaigns and things, are really led by them, and really pushing them to involve these more hidden populations and recognize that they exist, and building up their capacity to be able to provide services and response to them in a safe and differential manner.
Thanks. And then another question, going back to the kind of context that you described around El Salvador and the conflictual context that it is. We have a question around kind of coexisting in an environment which is gang controlled or gang accessed. And how do you kind of maintain that coexistence without getting into conflict with the gangs?
That's a good question. So coexisting, it's a very fine line. Typically, people that have grown up in these areas, they know each other, they know the gang members, they may have grown up with some of them, and so a lot of them don't see them necessarily as a threat, which is quite interesting. Some of them even see them as a leader within their community, or somebody that's brought some sort of positive change within their community, and that's how gangs really gain control, because by also gaining buy-in from people within. But it's a fine line, because you have to know what you can do and what you can't do. You have to know where you can go and where you can't go, and you have to follow the rules. If you don't follow the rules, then you are subject to being ousted or to violence. And one of the most common sort of techniques is threats, right? And those threats are definitely made real, and using people close to you, and surveillance of movement, etc. So I think people get by being quiet, not looking, making sure that they keep to themselves as much as possible, and that definitely does have long-term mental health implications. So coexistence, while it sounds not so harmful, it really is, because it's a forced coexistence, and this is particularly damaging to small business owners, or people that are working in sort of informal trades, because if you work within that territory, you have to give a % of what you make to the gang. If you don't pay, then you are in potential risk of being hurt, or your family being hurt or killed.
Thanks, Katie. One more specific question about the particular marginalized group that you've talked about before we get into the more general questions. Someone's asked if you could talk a bit more about what the housing situation is like for LGBTQI people in El Salvador, because from their own work, they found that this is a particularly concerning area for this vulnerable population. Do you have any thoughts about that in particular?
Absolutely, that's a very good question. The housing situation for this particular group is not good. People, if they have the ability and courage to be able to feel safe enough to come out to their families, many of them are ousted, and that means being ousted from whatever home they live in, which may not be the most comfortable, affluent place, but they have a roof over their head. Unfortunately, this puts this particular population, especially trans women, again, because of just the notoriety of being able to know that they are a distinct population at risk. Many trans women in particular start working in sex work. They start working on the streets. They start trying to make money for themselves in what they can, and that might mean going through some really sort of negative coping mechanisms to do so. And then we also just see a lack of reliable shelter here because of the urban population, and also because of the lack of trust. Most of the shelters that do exist are very closed, and they're not accessible after 5 p.m. and until 9 a.m. the next day. And if it's a weekend, well, you're out of luck. So you tend to see a lot of this population on the streets as well, if they do get kicked out of their homes and they're not taken in by a friend, and it just puts them at more risk for potential exploitation. And yeah, unfortunately, we have the same problem here, and there's not an easy answer. I know many organizations have been interested in doing a specifically trans sort of targeted shelter, and what a lot of them have come to start doing is just giving out like subsidies, and that's something that some of our cash programming is also supports with, where because there's so little amount of shelters that are really accessible for this population, a lot of trans women are not allowed in the general shelters because people don't consider them men or women, and so they sort of are ousted from both specialized areas. And then so what some organizations have started doing, and we've done the same, is giving out cash transfers specifically for supporting with shelter housing, and that typically looks like a motel or something of that sort.
Okay, great, thank you. So we'll move now to some of the questions that have been asked, both when people registered and those coming in now, that talk about this kind of topic kind of overall, because obviously each of your presentations have addressed a different marginalized population, but I think there are a lot of similarities, the experiences of marginalized people, and there are obviously other marginalized groups that we haven't talked specifically about on the webinar today. So the first question I'll ask each of you, and maybe I'll turn to Valerie first and then get your thoughts afterwards, Katie, is how do you find who is representative of a marginalized group, especially if these individuals are hidden and not necessarily easy to identify? How do you know, if you find someone who belongs to that group, if they might be representative of that group, or if you've just found a one-off opinion, especially considering how much it's important to try and engage affected people throughout the humanitarian programming cycle. How do we find representatives of marginalized groups? Over to you, Valerie.
Sure. Just in general, how we find somebody who would represent a vulnerable group. I mean, the first tier sort of vulnerability or marginalization, we can look at economic vulnerability. So when we're targeting those locations, we can know by location, or which would either be by neighborhood or by the settlement in which they're living, if they have economic vulnerability. And of course, then there's other layers that add to that vulnerability based on the group that they're a part of. So it could be that they're elderly, it could be that they're children, it could be that they're disabled, it could be a number of factors. When it comes to representatives in sort of the group setting in terms of who would represent as a group, it really will vary based on the setting. So sort of more of the informal settlements, you will find usually in Lebanon what they call a shawish, which is basically a representative that's nominated or appointed by the community itself, that might represent themselves to the humanitarian community. And we do work with those individuals to ensure that they have an awareness about the importance of what our programming is, although we actually do work directly with the individuals within those communities, and not just with representative. In other circumstances, circumstances, it will be, for example, the nominated representative of the collective shelter, or it could be a prominent person within a neighborhood if we're talking about, for example, an apartment building or a neighborhood. And then, of course, you also have potentially, again, depending on the specific context, a local religious leader or a mukhtar, somebody who's has local authority, but on a very local level. So it really will just depend. And we do think that that working with these people as well is really important. It really helps in terms of ensuring that we're addressing the reduction of stigma and basically facilitating the need and access to primary healthcare centers where it's relevant.
Thanks, Valerie. Do you have any thoughts on that one, Katie?
Yeah, I would just say, particularly for the LGBTQI population here in El Salvador, we have to dig deep and go beyond sort of the big names of people that we know work within the field, or organizations that we know work within the field, and really talk to people on the ground. And I think that's where you'll find out how if somebody's voice is really representative of the majority of the population. There's a lot of layers of complexity within that. We found that, you know, a lesbian woman in El Salvador may not feel comfortable with a trans man. And they may not have a lot in common. So their community representative may not be the same. So don't assume. And really try to talk to a diverse set of people within the group, and know that experiences can't be prescribed. One person's experience can be very different from another's, depending on what their sort of social support network looks like, and particular experiences have looked like. And I would just say, you know, typically in El Salvador with other populations, you would be able to rely a lot on the religious, on the Catholic Church, on the Evangelical Church, because they have a very strong presence in the community. Unfortunately, with this particular population, that's not a community representative that you can really trust, particularly because of a lot of the marginalization that they themselves have done. It's not an actor that the community really sees themselves in. So I would say, you know, it's not going to be just one community representative, and I think we need to be okay with that.
Great, thanks. Going back to you, Valerie, I wanted to ask you one of these questions that was submitted by someone who registered for the webinar. Do you know of any shareable examples where crisis response has been linked to sustainable solutions for particular marginalized groups?
Sure. So I think actually Lebanon provides a good example of where there is a direct link between humanitarian assistance and sustainability. In many circumstances, again, to the extent possible. And that's because all of the refugees, and again, speaking specifically about the Syrian refugee context, are living within the communities, within Lebanese communities. And so the services that they access are also services that are available to Lebanese, whether that be in health, mental health, also education, also when it's possible, work, so the informal economy for refugees. So by the engagement that we have as humanitarian actors with the government, we are actually in a process where we're supporting humanitarian needs, but simultaneously actually building the capacity of the government to respond. And also, when and if the Syrian refugees do leave, they will be at a more strong position to serve their own people, which also have vulnerability. So there's actually a number of examples when it comes to mental health. Since we're focusing on mental health with with Ari's presentation. I think similar to what we were mentioning with one of the earlier questions, because we are working actually within the primary healthcare centers for our psychologists and our psychiatrists, although we're doing the community health outreach, we're also finding, as our programming has gone on, we're actually finding an increased number of patients that are coming without having received outreach or awareness from us, seeking mental health services. So we believe that this actually is demonstrating that what we're doing is actually having a sustainable impact beyond just directly with the patients that we're directly targeting.
Great, thank you. And Katie, especially given what you already mentioned about your work engaging with local authorities and also things like religious authorities, do you have any thoughts about the role that humanitarians might be able to play in advocating or engaging with these authorities who, in the case of, for example, LGBTQ individuals, may actually be taking actions that exacerbate marginalization rather than addressing it? Is there a role for humanitarians in this?
Yeah, I think there is, and I think there has to be, especially in Latin America. You can't do this work without having doing advocacy at the same time, and it's a bit of a sort of non-traditional marriage, because humanitarian work, you don't necessarily think of advocacy and policy sort of influencing at the same time. But I think specifically in the Latin American context, you have to, and you have to do that in a very subtle relationship-based way. So I think finding, that person within the particular institution that you know is very committed or interested in a particular topic, and they may not be, for example, in agreement with trans people having access to an ID that has a new name on it, and says a different gender, but they may be open to dialogue. And I think it's finding that right person within the institution or governmental organization with who you can start that dialogue and relationship, because it's particularly in Northern Central America, relationships are everything. If you can make a relationship with somebody, then any sort of advocacy or a change that you would like to do on behalf of a population, or involve sort of them in being a champion on a particular issue, is much easier and feasible, and they'll consider it because they have a good relationship with you or your organization.
Great, thanks. I know we're trying not to focus on coronavirus here today, but we've inevitably had a few questions submitted about the relevance of this topic, with this unprecedented pandemic that the world is now experiencing. So there's a couple different angles to this, and I'm going to combine them together and then ask each of you your thoughts. So in a situation like this, where so many individuals in each country that's affected by coronavirus will be visibly in need, how do we meet the hidden needs of the marginalized in this situation? And is there a risk that marginalized people can be left further behind as a result of something like the COVID-19 pandemic? And what can we do about it? So I'll turn first to Valerie, and then I'll go over to Katie for your thoughts on this one.
COVID-19, it's the hot topic. Just to say, in the context of Lebanon, and I know it's sort of happening worldwide, but we in Lebanon, we actually had our first case on February 21st, and we've been experiencing progressive shutdown. And basically since mid-March, we've been sort of in a lockdown mode. And that includes lockdowns within municipalities, which does mean that access to refugee populations is becoming more difficult. And that's for vulnerable populations in need. In addition, because of the lockdown, we know very much that the economy, which is already suffering, will also be taking an extra blow. And again, I know that's happening worldwide. But in Lebanon, we know that that's going to be impacting the level of vulnerability is going to be spreading. And certainly those who are already vulnerable will become even more vulnerable. So as a humanitarian community, we are doing our best to look at alternative modalities to reach those in need. When it comes to our mental health programming specifically, we are continuing with our patients via telephone. And we're ensuring that we're having regular follow-up with each of them. And one of the things that we're doing in addition is we're making sure that we actually will not be closing any cases during this period. So the mental health support will be ongoing until the lockdown is removed. This is because we do recognize the additional stress that's being caused, and we don't want to leave any of our patients, even if their initial issue that they're seeking support with has been addressed. We want to make sure that we're continuing that support. There are other modalities that are being looked at other sectors. Of course, again, the issue of access is very difficult because NGOs do not have permission to go around the country unless they have specific mandates, specifically, for example, related to health and WASH. So there are a lot of challenges that are being faced in terms of remote implementation. So it is something that is evolving, and it's fully recognized that we expect the level of vulnerability to increase quite significantly over the coming months.
Thanks, Valerie. It's really, really interesting to hear what specifically is happening in Lebanon and your thoughts on this. Over to Katie for any further thoughts you might have.
Yeah, so specifically in El Salvador, it's been an interesting sort of progression in that Nayib Bukele, the current president, really responded cautiously, and which I think he's being praised for internationally. He put very strict measures in early before cases came out. And similar to what Valerie said, we've also been on lockdown, except for essential services, since the middle of March. I'm going to focus particularly on the deported population. So many may not know this, but the deportation flights of Salvadorans to El Salvador from the United States have not stopped. Mexico has stopped deportations for temporarily, but particularly the United States has not stopped them. And so this is creating quite the conundrum within the country as the quarantine centers grow. There are now over 80 quarantine centers around the country with over 4,000 people in them, and there are 6 of those quarantine centers that are specifically for deportees or returnees to El Salvador. And so a very different demographic that you're seeing in other quarantine centers where maybe they had traveled by will outside of the country and came back. So essentially, many of these people are going from one confinement situation to another. They may have fled El Salvador because of confinement within their own home, because of threats or violence, then went to the States, got put into a detention center, and then come back into a quarantine center. Obviously, for public health reasons, it has its advantages. Unfortunately, these deportation flights are sort of now being used to bypass due process for asylum seekers. We also know that particularly because of these restrictions that the government has put into place, 95% of services have been closed. So those that are particularly vulnerable, people, women, girls, the LGBTQI population that may need particular services and it may not be able to get them right now. We have continued our CUENTANOS platform. We've continued our cash provision. We're also doing some support within the quarantine centers that are dedicated to deportees. But we know that this it further complicates things and is kind of importing still the virus back to the country, and not necessarily considering the ramifications it could have for El Salvador. I think it's going to continue to get more complex, and we're going to have to look at how we can reach that particular population as well once they leave quarantine centers. If they were already a population that was hidden and difficult to reach, I think this puts another layer. We also don't have permission to mobilize within the country, given that we're not a health responders particularly. So we're looking at sort of different solutions and really building upon the use of technology and two-way communication mechanisms to provide support to our partners as well as to the population in need.
Great, thanks so much to you both. Because we only have 5 minutes, and I know some people have to head off to go to their next meetings, I'll just say that when you leave the webinar, a survey will come up. It's only a few questions. If you don't answer it, you'll get a reminder by email tomorrow. Please do share your thoughts and tell us what you thought of the webinar, because we find this feedback really valuable in planning future webinars. And thank you all for joining us. We still have a couple more minutes, so I'm going to turn back to each of our speakers to hear any final thoughts you might have. Perhaps if you could think of maybe one thing that you'd want people to take away when they maybe go forward and consider working with the marginalized population that you work with in an urban area. Is there one thing that they should definitely not forget? I'll turn first to Valerie for any closing thoughts you might have.
Sure. So thank you. I think my closing thought is rather basic and maybe obvious, but it's just something I really want to stress, and that is the importance of mental health. It really should not be overlooked in the interventions that we're doing and with the populations that we're working with. They really are under very high levels of stress. Many of them, again, have experienced traumatic issues. So I think it's really important for us to, while at the same time we as humanitarians are obviously meeting their basic needs when it comes to other primary healthcare support, when it comes to, for example, cash assistance, so meeting some of their basic needs, education provision, all of the other things, wash, food. Really, mental health needs to be also on the top of that list. So I would just like to highlight that. And I think that with the COVID-19 situation that's happening, the mental health needs will grow considerably, not only with those who already have been identified as in need of mental health services, but a growing population, because it has put all of us under stress, and particularly those that have less financial resources or find themselves within a more vulnerable situation are going to be under a great deal more of mental health issues. So that would be my closing message.
Great, thanks very much, Valerie. Over to you, Katie.
Yeah, I think I would just emphasize to start where they are. Don't assume that we know best or that we know what the needs are for particular populations. Don't group them together, and really do your due diligence and ask and speak to diverse sects of the population before even designing programming. And I think that really sort of hits home something that we talk a lot about in humanitarian sector as well as in the development sector, that things need to be co-led or co-designed, and feedback mechanisms are so important. But I think that it's really a time to put that into action and let some of these projects and programming be really led by the person of interest. And then finally, I would just emphasize, build programming around these rather than in trying to fit our programming into a specific context. go into the context, explore the context, and see what it tells you. And that might mean being uncomfortable at times. That might mean having to try out new technology or new ways of doing things. But I think that's where we see the breaking point. I think that's where we see learning, and I think that's where we really can create new evidence in terms of what can work for urban populations, especially marginalized groups.
Great. Well, thanks again to both Valerie and Katie for really interesting presentations and discussion and answers to those questions. Thanks to all of you who've listened to the webinar and stuck it out to the end with us. Thanks to my colleagues behind the scenes, Danny and Maria, who've been making sure that the webinar happens smoothly. A couple final reminders from me. The webinar was recorded and will be available in a couple of weeks. The link will be sent out to you as you've registered for the webinar, so you're welcome to share it with anyone who couldn't make it today or refer back to it as a resource. Please do answer that survey. It's really helpful for us to continue to improve these urban webinars. And most importantly, especially in these very challenging times, stay safe, take care of yourselves, and we hope to see you at the next ALNAP Urban Webinar in a few months. Thanks again. Have a great day.